a recognition, and we have access beyond surgical therapies, where once upon a time only the valve surgeries were there, now interventions are there. We have a very strong surgical teams in our hospital. At the same time, our structural heart disease intervention program is extremely strong. Sai is one of the biggest leaders in the country and probably in the rest of the world as well. He has toured several countries and does some of these procedures outside. We have, I have great pleasure in introducing Sai to this audience. He will be in the main person dealing about the TAVI valves and the Mitra clip, both together as one panel session. And we have other experts as well. Vijayakumar, Srinivasan, Poorna is a heart failure specialist who does a lot of echoes during these procedures. And of course, Refai is a well-known cardiologist who does a lot of procedures along the entire spectrum. Take over, Sai.
Thank you, YVC. As usual, he is very generous with his compliments, and I hope I continue to live up to how much he's extolled me. But without much ado, I think all of you have seen enough about TAVI. It's been done and dusted and bludgeoned down your throats. So I'm going to very quickly just go over a few scenarios. At our hospital, we have one of the highest volume structural centers probably in India. We use all kinds of TAVI valves. You can see on the left is a Medtronic Evolute Pro valve. On the right is the new Navitor valve. Here you see the Sapien valve in the aortic position, and you see the My valve in the mitral position. Not only that, we are comfortable with putting TAVI valves in failed surgical valves. So if you look at the image on the left, you can see way back in 2017, we have been putting TAVI valves inside valves that surgeons have implanted that have failed. So you can see a 23 perimount valve that has failed with a Medtronic valve in it. Here you can see a Sorin soprano valve that has failed, and you can see the various types of valves, how they look on fluoro. Doesn't matter what valve the surgeons use, when they fail, we go back, put TAVI valves with good results. Here you can see two other valve types, all way back in 2017. So we're doing this work, we've been doing it routinely. Now, not only have we been putting TAVI valves in native anatomy, we have been putting TAVI valves for aortic stenosis, we have been putting TAVI valves for aortic regurgitation, we have been putting TAVI valves in failed surgical valves, and we have been putting TAVI valves where mitral valves have been replaced. Mitral valves have been replaced with multiple metallic valves. Here you can see a tilting disc valve, and there you can see a bileaflet valve. This takes a little bit of skill because you have to make sure your TAVI valve doesn't interact with these valves. Also, you cannot stop anticoagulation when you put these valves in. So it takes a little bit of coordination between your colleagues and your team. And as usual, this is never a one-man show, it's teamwork. I'll come to that after I finish my presentation. With that, I'm going to jump straight into mitral procedures. Because this is fairly new, I'm going to take about 6 to 7 minutes and then hand it over to the panel. Dr. YVC, is that okay? Okay. So 26 million cases of heart failure are diagnosed worldwide. About 38 million if you look at the undiagnosed cases. It's the number one cause of heart hospitalization in the world today. We all have a 1 in 5 risk of heart failure-related hospitalization. And the thing is that over 50% of these patients will get readmitted to hospital within 6 months. Why? Increasing life expectancy, diabetes, hypertension, coronary artery disease, like all roads lead to Rome. Wherever there's myocardial damage leads to heart failure. Mitral regurgitation is a significant factor that worsens the outcome in these heart failure patients. As such, mitral disease is 2 to 3 times that of aortic valve disease. Even in a country like America, 4 million cases of mitral regurgitation are diagnosed every year. Only 1.5% of them are treated. What is the Mitra clip? The Mitra clip is a transcatheter procedure which identifies the leak, clips the leaflets of the mitral valve together, creating a tissue bridge, abolishing the leak, reducing LA pressure, and improving quality of life and longevity. Now, the first Mitra clip was in 2003. 2 pivotal studies have defined, so we've just turned 20 years of this Mitra clip therapy. 2 pivotal studies. I'm not going to go into the details. What did they say? 1, Mitra clip was safe. 2, it improved quality of life. This quality of life was sustainable. 3, it reduced hospitalizations. 4, it is the only therapy to date that has improved longevity. If you look at statin use, what is the percentage of mortality reduction in statins? It's like what, 0.1, 0.2? You compare that with MitraClip from the COAP data, it's 10%. So this is life-saving therapy. Expand, mimicked what COAPT showed, but it showed that not only was the result in functional, what is functional mitral regurgitation? Where the muscle is damaged, cardiomyopathies, MIs, ischemic cardiomyopathies, where the whole LV dilates and pulls the mitral valve apart. Then you have degenerative. What is degenerative? Where the valve is involved, caudal ruptures, rheumatic heart disease. So it is shown that not only in the functional, but even in the degenerative, MitraClip is good. I'll quickly blow through a few cases. So functional mitral regurgitation. This is the group that surgeons won't touch because mortality is high, EF is low. These are the morbidly sick patients who you will see EF 20, EF 25 coming to you over and over again with heart failure. 89-year-old male weighing 36 kilos, 2000 MI, large anterior scar, EF less than 20, progressively worsening, severe MR, 6 hospitalizations in 4 months, unable to be discharged at this admission, in the CCU for over 45 days on and off ventilator. Look at that LV. Huge dilated LV like a football bladder, barely moving, right? 13% ejection fraction. At this point of time, we spoke to the family. We said, look, this is not a case that MitraClip or any therapy is going to help. He's very sick. You waited too long. But they said, look, all we want him to do is come back home, doctor. We just don't want him to stay in the ICU any longer. So the big flame you see is the leak, big flame. You can see the clip with the arms open beautifully, the grippers coming down. Put one clip in, MR went from severe to nothing. LA pressures went down instantly. And this is his first post-op day. There's no video, but for the first time, he's off oxygen. He's on room air, and he's saying much, much better. A little bit of lip bleeding might be useful here, but that's what it is. So I'm not going to dwell on this video. This is how transformational this therapy is. So you can say, okay, Sai, this is 4 days later. Okay, your therapy works immediately. What about longer? 72-year-old male, diabetic hyperthyroid, PCI 2005, EF 25%, came to us crashing. First air ambulance refused to take him. Creatinine 2.4, liver enzymes in the thousands, metabolic acidosis, shutting down. BP 80-50, the first air ambulance from Delhi refused to get him on the plane. Managed to get a second air ambulance, miserably sick. Huge MR. The LV is so bad that even the leaflets are not closing. My anesthetist tells me, look, I cannot send him out of the table. You have to do something. We put one clip in initially, thought that we'll take what we can and go. But the minute we put the first clip in, the anesthetist is like, what did you do? This patient is doing so well. The heart is loving it. I'm coming down on supports. So went in, put a second clip next to the first clip. Can you see that big hole when the valve closes? That's supposed to be tightly closed. And you can see the second one, the alien-looking owl face. You can see a neat coaptation line. So we went from severe MR to nothing. VWAY went from 84 all the way down to 26. On table, the lactate went from 9 to 1. Blood pressure shot up to 130 from 80. Over the next 4 days, creatinine normalized, liver enzymes normalized. This is him 12 hours after the procedure. This is him 36 hours after the procedure. This is him 4 weeks after the procedure. Right? He's still doing well. So now you say 4 weeks, okay, Sai, what about longer? 80-year-old male, creatinine 2.5, cardiac arrest survivor, same scenario, surgical turndown, multiple hospitalizations. Look at the date, 2019. We put one clip in. Huge non-coaptation, severe MR to nothing. I'm just going to go past all this. 86 pressure down to 31. This is him at discharge. Every month from 2019, he sent me a message saying, good morning, sir, thank you for this miracle. He says, what all can a clip do? They diagnosed me for ILD. They diagnosed me for this. They diagnosed me for that. Everything went. He says, my father could never sleep. We used to wake up at 3 o'clock and have coffee together. I missed that. I said, it's a good thing to miss. So 4 years later, that is him holidaying in San Diego with his grandchildren. This is a cardiac arrest survivor in refractory heart failure. So I can go on and on. So that's 4 years later. But I think it's more important to discuss. This man had come to us who had forgotten how to walk. He was bedridden for 2.5 years. At this stage, even the neurologists and the other colleagues questioned me saying that, what are you trying to prove? An 85-year-old bedridden man, you're going and putting a MitraClip in? What is wrong with you? It's unethical. We analyzed the patient. We said, yes, he is bedridden because he has forgotten how to walk. There's no neurological problem. We went ahead and put a MitraClip. The son sends this from San Francisco. Dr. Sai, hope you're doing well. My father's doing well. 81 years, renal dysfunction. In spite of all this, I still think it was okay to take the decision we took. That's him watching TV. Okay, 1 month later. 3 months later, he's relearning how to walk. Okay? 6 months later, can you believe this is the same man? And now he's fighting with his family, saying that he doesn't want a driver during COVID, he wants to drive his own car. And they're telling me, please advise him to keep a driver. And I am surprised. I'm saying, is this Radhakrishna Gurumurthy? My God, what a miracle. So this is the transformational capacity. 5 years down the line, the daughter sends a message in March of this year saying, my father is doing well. Thank you for these precious moments with his grandchildren. So I'm going to stop with that. This is how transformational this therapy is. Thank you so much for the patient listening. I think I'm going to hand the panel over now for Vijay for further discussion. Thank you all. But before I go, I would like to say that at Apollo Chennai, we have now completed over 100 MitraClip cases. The 30-day mortality is 1 patient. That 1 patient died of documented COVID on day 28 during the peak of COVID, Delta. The results are probably the best in Asia. This program could not be where it is without Dr. YVC Reddy's support. We have done all our cases together. He is an incredible asset for any team, and I will always be grateful to him for how much he has contributed. Thank you so much.
Thank you, Sai. Wonderful presentation, and of course, we know what all magic he can do. And ours is a very, very sincere, dedicated team for the patient care. Now, this rest of the TAVI MitraClip, because these are new things. The technology is a marvel. We are discussing about mastery, as shown. We are discussing about the marvel of this technology. There will be several myths also. These are not for each and every patient. Dr. Vijayakumar is one of the important pillars of our team. He is going to moderate the rest of the session. Over to you.
Okay, good afternoon, everyone. For next 5-10 minutes, we just go through. Means most of the things already have been done, and a few of the things we'll just go through. So we'll just start with the discussion with the Dr. YVC Reddy from here. It is. Can we get the slides here? Slides. Yeah, it's not coming. So, which patient you consider TAVR in your clinical practice? So somebody comes with an aortic stenosis to you. So how do you select your patient for a TAVR procedure? Maybe when you make a referral and you know that which patient is for TAVR, which patient is for surgery. Yeah. It is.
See, very important for the audience to know that once you have a severe AS who is symptomatic and needs some therapy, the options are there, the surgical valve as well as the TAVI. TAVI has evolved so well, now we can do the procedure in very, very minimal risk. The only problem is should not be advising it for people who need a metallic valve. A metallic valve is needed for youngsters who are less than 50 years of age or so. They need a metallic valve because you need not be changing it. That is the usual criteria. Once it is not there, TAVI also can be offered. We have to discuss with the patient and family. If it is a moribund surgical turn down, straight away TAVI is the rescue. High risk patient for surgery, TAVI is the rescue. Moderate risk for surgery, TAVI is the rescue. Low risk patients, you have to talk to them because surgical also is a very good option. We have our surgical, some of the surgical colleagues as well in the audience. So being fair to the game, I think many of the patients can benefit except those who need a metallic valve. Our TAVI valves are tissue valves, which last probably around 15 years. But it's very easy that even if it is going to need a re-intervention after 15 years or 12 years, we can put one more TAVI valve inside that valve.
So we have multiple type of valves. Dr. Sai showed some 5-6 type of valves. Dr. Sai, how are you going to select offer your valve for the patients? Which patients you say that?
Whichever company is very nice to me. No, I'm just kidding. So the beauty is that we have the luxury of choice. And in 90% of the cases, either of the valve will work just as fine. But there are few specific scenarios where different valve designs have slight advantages. Now, to make life simple, I'll just divide it into balloon expanding and self-expanding valves. The self-expanding valves have an advantage in small annuli, like for instance, when you are going to put a valve inside a surgical valve. There are two advantages of putting a self-expanding valve. A, the coaptation point is higher. So basically you get better gradients with these valves when you're putting it inside surgical valves. The second thing is, depending on independent patient anatomies, if you have extremely calcified anatomies and you're concerned about using a big balloon, see, how does the balloon expandable valve work? It's a big stent that's mounted on a balloon and you smash that valve in place. But if you have a lot of calcium and you're concerned that you can damage, then you can take a self-expanding valve. What are the advantages of the balloon expanding valve? These valves are shorter. So if you're thinking of younger patients, if you're thinking of reaccessing the coronaries, if you're thinking of planning future procedures, these valves have a slight advantage. So then sometimes there are more anatomic specific, like if the aortas are very horizontal, it might be easier to get a balloon expandable valve in because the catheter can bend. But these are technical advantages and disadvantages, but by and large, all of them are tissue valves. Their durability in the data that's there till now is pretty much on par. Vijay?
Thank you so much. Dr. Srinivasan, when a patient comes to you, but how do you evaluate this patient for your TAVI? So any specific type of test you have to do for assessing the patients for TAVI?
Yeah. So basically, first thing what we have to do is we have to do a CT TAVI protocol. There is a separate protocol is there, CT scan TAVI protocol. If you tell, no, our radiologist will do it. And they look at the calcium. Basically, what we need here is, all these coronaries, we said calcium we don't want. But here, we want calcium. We want calcium here. So because, the valve has to get holded. So the calcium holds the valve. So they will assess the calcification of the, and they will see whether it is a tricuspid valve or bicuspid valve. That matters in the device selection also. And they look at the coronaries also, the proximal coronaries. And so these are all some of the parameters which radiologists will give us in the TAVI protocol CT scan. And of course, echo-wise, we are going to assess the LV function and other things.
Okay, thanks, Dr. Srinivasan. Dr. Refai, could you just explain them how this valves are performed? How maybe Dr. Sai showed the procedure already, but for how these procedures are done. I'll show you a video. Maybe you can just enlighten them how these procedures are done in the cath lab. And how do you do it? About anesthesia and other things, maybe you can just explain them how simple is the procedure nowadays it is.
Yeah, so currently, so remember when TAVI was started, the sheet size, the diameter of the sheets were 22 French for femoral access, and there are a lot of patients we could not do because they don't have significant femoral artery sizes to do it because of the age and calcification. So there are options like transapical approach, transaortic approach, and transcaval approach, transubclavian approach. But nowadays, thanks to the technology, there are improvement in the profile of the valve. So now we can do most of the TAVIs with the 14 French sheath, which is equivalent to around 5 millimeter in diameter or 4.5 millimeter diameter is enough to get through that. So essentially, we access the femoral axis. The commonest axis that's still present is the femoral artery axis. So you have a sheath inside and then pass a wire into the aortic valve. So usually we use a straight tip wire to cross the stenosis and then use a balloon to expand it. So usually we undersize the size of the balloon to the annular size on the echocardiogram or also in the CT. And then after that, we, depending on the device we use, whether it's a self-expanding or balloon expanding, then we take the device through the wire, which is the stiff wire, into the left ventricle, and then slowly release it if it's a self-expanding. But if it's a balloon expanding valve, you just keep in position and look from different angles, make sure that you're in the coplanar view or depending on the different aspects of it, and then you balloon expand the valve. If it's a self-expanding, you can slowly release the valve. Particularly in balloon expanding valve, we need to do fast pacing. So essentially, we need a temporary wire in the right ventricle, whichever axis you want to go, jugular or femoral or subclavian axis. And then when you do the fast pacing, your blood pressure drops down. There is no movements in the heart, and then you deploy the valve. So in self-expanding, you have a little time to deploy the valve. Throughout the procedure, you can also inject the contrast to check the position as we go along.
Yeah, I think the nicely explained. The procedures almost like in US, it has become a single day procedure. You do the procedure, next day morning patient goes. So most of the procedures are performed with the transthoracic echo and the conscious sedation like routine PCA. Sometimes it takes less time comparing to your PCA. And Dr. Poorna, any situations what do you think about it, the major differences between surgery and TAVR? So you think any advantage of doing a TAVR comparing to surgery or surgery versus this thing? So what are the patients suppose come and ask about TAVR? What are the things you just explained them?
So I think assessing the clinical situation and the patient is first and foremost important. So there are scores that predict the risk for surgery for every individual patient, the STS and the Euro score. So based on the risk score that you get and the profile of the patient, say if it's a young patient who will likely benefit from a mechanical valve, then you go for a surgical option. Or if it's somebody who is slightly not too young, not too old, but they're at moderate risk for whatever reason, like say LV dysfunction, or they don't want to undergo an open heart surgery, then I think in those patients, based on the risk scores that we get, we choose TAVR. But in some sense, I think we also evaluate the patients. A lot of patients who have heart failure with preserved ejection fraction, they have what it looks like severe aortic stenosis based on what we look at the morphology of the aortic valve by echo, but their gradients may not be high enough. So this is always the question as to what is happening here. So in these kind of patients, sometimes we do assess them with a dobutamine stress echo, where we inject, we place people on infusions of dobutamine and then look at the contractility of the heart, the gradients, and then the calculated aortic valve area. So in these patients, if there is an improvement in the contractility, like say the stroke volume improves with the use of dobutamine, the gradients improve with the use of dobutamine, and the valve area still looks like it's fits in the severe range for aortic stenosis, I think these patients definitely have a better outcome, and we can go ahead with whatever the modality that they choose, which is probably most likely in these patients TAVR if they're older and have other comorbidities. And one other thing is that a lot of these patients with HFpEF and severe aortic stenosis do tend to have something called as this transthyretin amyloidosis, which can be a wild type or a mutant. So it is sometimes important to screen these patients who have severe AS with heart failure for these kind of evaluations for transthyretin amyloidosis, because these patients we have to assess them and see what their prognosis is going to be, so that they can be well informed, and the therapies for controlling blood pressure and managing their heart failure will still be done post-procedure.
Thanks, Dr. Poorna. Dr. YVC, do we have data that these valves are durable?
See, this program, TAVI, has been going on for quite a long time now, and minimum of 15 years. This is the average, if you can take the valve, surgical tissue valves also. This is also the same. There are certain features about the tissue valves, the way they are prepared. Some are porcine, some are bovine, but the way they are treated, I think most of them are quite durable. The need for anticoagulation, like in any tissue valve, normally we say anticoagulation is maybe needed in surgical tissue valves for about 3 months, and then we go to single antiplatelet. Even for our tissue valves, so the TAVI, a single antiplatelet is good enough. In certain scenarios where you think there might be an increased chance for thrombus, we sometimes use double antiplatelet or a short-term course of a Novak as well, but predominantly one antiplatelet is mandatory, at least for the first 3 months. Of course, if there are other indications for anticoagulation, we should continue that. The durability is not at all a question, because the alternative available is a surgical tissue valve, which again is the same group.
And one final question to Dr. Sai Satish: can you do a second valve in a TAVR valve already implanted in a patient? Suppose it comes with a failure.
Definitely we can, but it comes with its own baggage, in that unless the patient anatomy is tolerant enough to allow for a second valve to be implanted, it's not like we can put up. So the beauty is that when we initially started putting these valves, it was a bailout procedure. But now the guidelines have expanded from the prohibitive risk patients who never survived the duration of the first valve failure it went to the high-risk patients who never survived the duration of the first valve failure, to the moderate risk patients who will survive the first valve. So now we are talking about something called lifetime management, where we plan, saying if this patient has come for a valve to us at 70 years, we say that, okay, he's going to live to be 90. So what valve should we choose first based on his anatomy so we can go back in and put a second valve? Because when this valve fails, the largest data we have, or the data that the rest of the world goes by, is the data presented by the Nordic group, which is called the Notion trial. And the 9-year data shows that this TAVI valve matches surgical valves. Now, what do you know about surgical valves? 1967, Carpentier and Edwards in 2 separate labs perfected the glutaraldehyde process. So from 1967, over 55, 60 years, we've been putting tissue valves. What are 2 things we know? Higher the gradient, sooner the valve goes. Younger the patient, sooner the valve goes. There's no reason to not believe that the TAVI valve, which is the same tissue valve like Dr. YVC Reddy said, will behave the same way. So keeping all this in mind, we have to be very cognizant on how old the patient is and what therapy we offer him first.
Yeah, one final question to see. Do all the surgical patients to be treated with the tissue valve to keep a TAVI valve in mind? Maybe any of you can.
Me?
And yeah, any of you can.
100%. I think you should bury the metallic valve unless the patient is maybe 45 or younger. I think that the way technology is going, if I told you 1.5 weeks before man landed on the moon, I think 69, July 69, I think, I don't know, I'm really bad with dates. So you'd have thought I was an idiot. But now people are routinely going to the moon, right? I think the beauty of medical technology is never be the first to try the new nor the last to leave the old. If you're in between, you're safe. There are already patents being filed for valves. No valve we have in the market today is a perfect solution for aortic stenosis. Each has its own disadvantages. But the minute they get a valve which is synthetic, which works well, that'll be the single valve you put for the rest of the patient's life. So keeping all this in mind, I think unless the patient is very young, I would offer the patient, telling him that, look, because you're young, you might need another valve in 7 years, in 8 years, but we should offer the patient.
Okay. Thank you for this thing. So just maybe 1 or 2 questions about Mitra clip. Dr. Srinivasan, which patient in your practice consider Mitra clip therapy rather than surgery?
So prohibitive risk, what we call the surgical risk, is very high in patients with severe mitral regurgitation. Then we have to, we can consider this Mitra clip in place of surgery. So patients who has very severe LV dysfunction and multi-organ dysfunction, like liver in trouble, kidney in trouble. So the prohibitive risk, and by surgery, they quote surgical risk by scoring. And when the score is very high, such patients probably a good choice. Mitra clip will be a good choice.
Dr. Refai, do you think Mitra clip should be continued? Should be considered as a continuing heart failure treatment? So beyond what we have, medical treatment, surgery, and you have CRT, all these things. Do you think it should be part of management of heart failure continuum? Mitra clip, because mitral regurgitation is one of the part and parcel of your all heart failure patients.
Yeah, absolutely. I think as Sai was mentioning about the outcome data for MitraClip from the co-op trial suggested that your mortality reduction is quite significant in patients who have severe mitral regurgitation and LV dysfunction. So if you have an LV dysfunction patient who have a mild MR, you may not consider. But if you want to consider all medical therapies and the MR is not getting better, and if you have moderate to severe mitral regurgitation, I think we should consider MitraClip for those patients, because we know the pharmacological treatment of heart failure is up to a certain extent, but they not correct the mitral regurgitation as such, particularly when they have more than moderate mitral regurgitation.
Thank you so much, Dr. Roy. One final question. Dr. Poorna, do you think MitraClip won't benefit in particular type of MRs or particular type of morphology or patients, particularly in relation to heart failure? So which patient you don't consider heart failure patient for MitraClip therapy?
Sure. So again, there are always exceptions to every rule and every inclusion and exclusion criteria. But in general, in patients who have very dilated heart, dilated cardiomyopathy, where the end systolic dimension was more than 7 millimeters, 7
Centimeter.
centimeters. And if it looks like it's a functional MR, then in those kind of patients, there was less benefit, or if the ejection fraction is less than 20%. Again, we have Dr. Sai, presenting some of the patients.
All the patients I presented by what Poorna is saying cannot be done. But in Mitra
I'm not saying it cannot be done.
I'm
That's
just kidding.
why.
I'm just sorry, please finish.
No. Again, like initially the co-op trials and the Mitra FR, there is always discordant results between the two because of the kind of patients that they chose. But I think in patients, definitely Mitra clip, like you say, there's a patient who comes in shock, and then there is no other way his blood pressure is low, you can't give them medications at that time. I think if the valve morphology is suitable, I think it's definitely worth trying Mitra clip, so that there is more blood flowing forward to actually implement guideline-directed medical therapy for those functional MR patients. So in that way, I think when somebody presents with florid shock and their mitral valve morphology and all the parameters that we look at in echo are suitable for a clip placement, I think we should definitely go ahead with it. Because those patients, when they recover, they have somewhat of a better blood pressure. So I do care for a patient who was not able to be on any medications and now is on Vimada and is doing a lot better. So, I think the clip helps reduce the severity of MR, improve the cardiac output and the stroke volume, improve the blood pressure, well enough for these patients with functional MR to be able to be placed on guideline-directed medical therapy.
Yeah.
So I think even the trial said that Mitra clip plus GDMT did better than either alone.
So just, if I may, just one comment. So the FR patients didn't do well, the COAP patients did well. What does data tell us? There was a registry called the Mitra Registry, 19 countries, patients randomized to heart failure or Mitra clip. What it told us is 24% of patients who were given Mitra clip went off the heart failure list. The whole patients in the Mitra registry were not COAP patients. So what do we know from this? In functional MR, that is in patients with cardiomyopathies with secondary MR, Mitra clip works. The reason it works even for the patients that it didn't work in earlier is because operator experience has improved, GDMT has improved, and Mitra clip is only given when patients are not able to have a good quality of life on maximum GDMT. The gold standard is guideline-directed medical therapy, plus or minus AICD, plus or minus resynchronization therapy, with Karthikeyan sitting there. When everything is said that in spite of best practices medical therapy, resynchronization, still MR, still heart failure, Mitra clip. Now, no surgeon will contest that it works. I want to close this with one question for Vijay. Now, you take degenerative. So functional, there's no dispute. It's TER. Whether it's Mitra clip, whether it's Pascal, you take degenerative. If you have caudal ruptures, flails, in 50-year-old, 45-year-old, surgeon will repair. But I want to ask the audience a question. What do you think is the best valve that you can have? What do you think is the best valve that you can have if you have valve dysfunction? What valve do you think is the best valve? Do you know what it is? It is your own native valve. So the rule is to preserve your native valve as long as you can. That is why Mitra clip will stay. Because it repairs your valve, and putting a clip doesn't mean you can't go later. So the question I have for Vijay is, if you have degenerative mitral regurgitation in a 65-year-old man, would you send him to a surgeon or would you put a Mitra clip? Now that's a controversial question.
Yeah, still the guidelines favoring surgery for primary MR than this. But person is high risk for going for a surgery and a very small prolapse, which very much suitable for Mitra clip. Still it can be considered, but still it is a class 2B indication, not a class 1 indication. And one final thing, how early in heart failure you consider your Mitra clip therapy? Because this is a very important question. If you see all the data, the mortality is so high, 2-year mortality is 50%, even though Mitra clip improved your outcomes. But if you see the overall mortality in COAPT is 57%. So the message here is when you feel the patient will benefit from mitral regurgitation treatment, and do them early. that is a message. Even though guideline recommends, I think near future, we are going to have newer guidelines that says early you address MR and better the outcomes in your patients. Thank you so much for this opportunity.
Thank you.